provided to Mercer, Morehouse, and Emory for Georgia residents that attend medical school there. This is a 6.7% reduction as well, $236,060. Also, I'm going to continue on. I'm also the director of the State Medical Education Board, which is an attached agency to DCH as well. There are 3 cuts under that board. 1615.4. We had started a contract with the Georgia Student Finance Commission to help us administer our scholarship tracking program. That amount was $15,000. We have, the board did put this in recommendations to cut, so that contract has now been canceled. 1615.5, decrease funds for the annual medical fair to recruit physicians to rural communities. This is an annual event that the State Medical Education Board holds where we bring rural communities together in one location and invite residents from all over the southeast to attend to try to attract residents to Georgia. That's a reduction of $8,348. And 1615.6, decreased funding for medical scholarship awards. This is one of the oldest programs in the country. It's the Country Doc program, and this is reducing it by $60,000, which is roughly 3 scholarship awards. So I'll be glad to answer any questions.
I'd like to ask one question. At yours and the board's request, I have introduced legislation. In fact, I must slip out at 2 o'clock. It's up in Health and Human Services that effectively allows you to accept donations and gifts and so forth from private sources. You want to speak to us just for 1 minute about that?
Hold on just 1 second. I think I actually left it in my folder.
I mean, just give us an example of what you think.
It's to help us fund additional research projects where we don't have any the funds to do it, like the GME expansion study that the funding was provided for, but it's now been removed. More detailed in and out migration studies, physicians coming in and out of the state, to help fund initiatives and incentives to keep physicians in the state to practice, are just some of the examples right off the top of my head.
Thank you. I don't see any further questions. Thank you very much.
Okay, thank you.
Well, 1 minute. We just ginned up one. Representative Gardner.
Thank you, Mr. Chairman. It just occurred to me that with the reorganization that's occurring, I meant to ask the medical board and your board where you're going and what you thought about it.
We've not heard. We don't know.
Thank you very much.
Thank you.
That finishes up the attached agencies, and now we'll hear from DCH.
Good afternoon, Mr. Chairman, members of the House Appropriations Subcommittee. Today I'd like to discuss with you an update on the status of the Department of Community Health Programs, as well as to present to you Governor Sonny Perdue's recommended budget changes for the amended fiscal year 2009 budget. And it's not working. What I thought I would begin with is an overview of the department's 3 publicly funded health insurance programs that serve the citizens of Georgia, as well as to discuss with you as well the administration and healthcare access programs that the department is responsible for. Normally I come and speak to you about enrollment and what the programs do, but in this particular instance I also wanted to point out to you the amount of state funds that are used to support these programs and the percentage of match that the state funds represent. And then in the last column is an example of the savings that have been able to be achieved at the end of fiscal year 2008 in the various programs. Most of you already know these programs very well. Some of you are newer, and some of you probably, I hope, will not remind a refresher. For the first program is Peach Care for Kids. Currently enrolled is 207,000 children in this program. Most of these children are coming from families with incomes of under 200% of the federal poverty level, which is about $35,000 for a family of 3. The income level does go up to 235%, but we are finding that fewer and fewer families at that higher income level are actually in the program. With respect to how much does the state fund this program, it does represent a 25% state share matched by 75% federal share. So for the end of for fiscal year 2009, the state funding for Peach Care for Kids was $98 million. At the end of fiscal year 2008, this department was able to return in savings $12 million. The next programs, or the next two, are actually components of Medicaid. Most of us tend to think of the low-income Medicaid being with Peach Care and the CMO program itself, but there is actually a second component, which is the age-blind and disabled population programs. In Medicaid, low-income Medicaid, there are approximately 956,000 children and pregnant women. The incomes for the individuals who qualify for this program varies according to the age of the child. Pregnant women and newborns are covered up to 200%, and from that point, the percentage of federal poverty level criteria goes down to as low as 100% for children aged 5 to 19. For the state share, 36% of it is funded by the state, 64% by federal, and the state share in terms of state dollars is $917 million in fiscal year 2009. At the end of fiscal year 2008, the savings achieved in this program and returned to the Treasury was $55 million. In the Medicaid, age, blind, and disabled populations, these are particularly account for not just this population, but also the fee-for-service in general. We are talking about 384,000 individuals. These are the elderly, the frail elders who need nursing home care or community-based services, as well as disabled adults and children. The income limits on this are variable. Individuals who are receiving Social Security insurance may have an income limit up to $8,000 a year. Other programs vary. This is also for the individuals who apply for nursing home care can have incomes up to $24,000 a year. This program also includes the medically needy, the Katie Beckett program, and the waivers in the Medicaid program that are administered both by this department as well as DHR. These programs are funded 36% state, 64% federal, which amounts to $1.1 billion in state funds used to fund the program in 2009. Savings in this program generated at the end of fiscal year 2008 was $47 million. The state health benefit plan, for which you are all very much aware of, right now we have an enrollment of 696,000 state employees, school districts, Board of Education employees, as well as the legislature and members of the judiciary. This program is funded 75% state dollars, 25% employee. The state share is approximately $2.1 billion. In the fiscal year 2008, $225 million were returned as surplus funds and added to the fund balance. With this change and noted improved savings, we were able to project that at the end of fiscal year 2009, the state health benefit fund balance would come up to $672 million. The admin budget for the Department of Community Health addresses everything from the General Counsel, Inspector General, IT, communications, all general operations, and human resources. In addition, it includes our contracts, the healthcare access portion, which we tend to lump together with administration services, includes rural health and grants to federally qualified health centers, critical access hospitals, etc. In all the healthcare access programs, there are approximately 62 different grants that are state and federally funded that account for almost $15 million in grant funding. that pass through this department to different providers across Georgia, particularly in the rural communities. In this program, there are $120 million state funds used. Another $10 million in tobacco funds was used to fund the Rural Health Regional Program that the governor initiated over a year ago. At the end of the fiscal year 2008, savings in admin and healthcare access was $19 million. All total, that comes to about $805 million identified. The bulk that you will see in Peach Care, low-income Medicaid, and ABD, as well as admin, were actually returned to the Treasury prior to the announcement of cuts resulting from the state revenue losses. The next slide I put up as an FYI for information only, and that is, okay, that didn't work. Okay, the next slide in your handout, ignore the screen. Ignore the screen. Shows you what I think is a very important feature of the Medicaid program, and that is how much a role the age-bound and disabled Medicaid plays in the Medicaid program in terms of expenditures. The age-bound and disabled populations account for about 25% of Medicaid enrollees when you add Medicaid and Peach Care together, but they also account for about 56% of the expenditures in fiscal year 2008. And if we were to break down categories of service in terms of the amount of expenditures, we would find that hospital costs would account for about 15%, but nursing homes account for 17%. The third largest category are community-based services in the form of long-term care waiver programs and the SOURCE program at 8%. Pharmacy programs costs have actually dramatically declined and are now at 7%. In comparison, for the 75% of the programs that are population that are in Medicaid and Peach Care who are children and pregnant women, that 75% of the population accounts for a third of the expenditures in the managed care program itself. Let's not use that. On your next slide is the DCH budget overview, what we will be reviewing today. For the Medicaid and Peach Care benefit budget, I'm going to review those together for you. At the end of fiscal year 2008, we've already discussed that for 2008, $114.9 million was returned to the Treasury in surplus or its savings. And for fiscal year 2009, I'm going to review with you the governor's recommendations for us meeting the 5% reduction in state funds needed in order to assist in the reduced state revenues. For the state health benefit plan for fiscal year 2008, we discussed the $225 million returned in surplus to the fund balance. At the same time, we noted that also with our projection revision for fiscal year 2009, that at that point we should have $672.5 million available in the fund balance for state health benefit plan. The governor's 2009 recommended budget addresses moving about $535 million of that aside and basically allowing that to be depleted by reducing the employer contributions that are paid into the state health benefit plan, leaving about $136 million in reserve in the fund balance. As far as the admin and healthcare access budget that we'll be reviewing, in 2008, the $19.3 million sent to the Treasury was already noted. For 2009, the governor has recommended a 23% reduction in that state funding. On the next slide, wasn't responded, is a summary of the funds again returned at the end of fiscal year 2008. The key areas being in the Medicaid program, Peach Care, and admin, but all total without the note of state health benefit plan, it's $134 million returned. For 2008 in particular, we wanted to point out to you the 9 different things that we think contributed to us being able to achieve the savings that we've shared with you and the surplus. and they include a variety of things from number one, removal of duplicate Medicaid IDs. It may seem like it would be a no-brainer. However, this was something that had accumulated. With the assistance of the FTEs that you allotted to us, I think a session or two ago, we manually removed 65,000 duplicate Medicaid and IDs from the system. That has a huge impact because then we were able to go back and recover capitated payments made to contractors for those duplicates. Next was the changes that occurred as a result of more stringent eligibility criteria being applied in the Peach Care program. Beginning in July of 2007, 100% income and citizenship verification was initiated. This actually followed January 2006 when the same 100% income and citizenship verification was implemented as well. The next on the list is the use of the care management organizations in the low-income Medicaid and Peach Care programs. And for fiscal year 2008, the state savings from the care management organizations was $11.4 million in state funds, $39.3 million total funds. In addition, with the use of the CMO fee, they were able to generate $90.8 million in net revenue. The next on your list is the disease management programs, which are used in the age, blind, and disabled population. This is a very coordinated, concerted effort to decrease the cost trend for the sickest and most disease-burdened population within the Medicaid program. So 100,000 individuals were actually enrolled in 2 disease management programs, and they were able to effectively reduce the rate of expenditures by improving care coordination across the board for individuals who had diseases such as heart disease, diabetes, hypertension, etc. Next on your list are community-based long-term care services, which includes the SOURCE program, which did a tremendous job in actually helping us have people be able to age in place and to be able to live in their communities. Under this program, we've had an increase in participation in SOURCE of about 35% and a reduction in nursing home bed days of about 2.4%. The next on the list is the use of Medicaid program integrity, or actually not just the use, but the increased use of Medicaid program integrity. Program integrity for this year was able to recover $27 million. This includes global pharmaceutical settlement agreements as well. In addition, we were able to achieve successful legislation with you last year in the implementation of a False Claims Act, and we are very happy to see that there are providers who have been able to use that to self-disclose to us issues that they know would be of concern. And then next on the list are the things that most state agencies have had to address, although we may have been addressing them perhaps a little bit earlier. There are about 486 approved DCH FTEs. At this point, given the attrition rate, selectivity in terms of hiring initially, and now the hiring freeze itself, there are now 79 vacancies, or a 16% vacancy rate. In addition, we've also reduced operational expenses and have applied more stringent controls on contracts and grants administration, meaning grants and contracts are reviewed on a regular basis and discontinued when not needed further. Am I having a TIA, or did it just get dark in here?
I think somebody in the back of the room leaned up against the light. Thank you. So turn the light back on. Thank you.
You don't know. There are days. And the last on the list is the state health benefit plan. The savings that were achieved and were actually able to be moved over into the fund balance were achieved because of a comprehensive approach addressing both improving administrative efficiency by reducing, if you recall at one point, 17 different plan options down, and then contracting out and developing 2 statewide health insurance companies to provide 5 health plan options to our members. This is a slide that I think that we show you each year as a reminder of cost control initiatives that have been put in place in years past and that continued to date. In 2004-2005, we began the Pharmacy Benefit Management Program, which included the PDLs, very aggressive supplemental rebate negotiations, quantity limits. We also began at that time a reduction in the outpatient hospital reimbursement. And what's not on that list but also did occur at that time was the use of a vendor to help us assess radiology services usage and utilization. In fiscal year 2006, this was a huge year. It included the rollout of the care management organizations for the low-income Medicaid and peach care population. For the age-bound and disabled population, included the implementation of the disease management programs. The eligibility criteria in terms of 100% income and citizenship verification in Medicaid began in January of that year, and the policies were more stringently applied for emergency medical assistance for immigrants, the Katie Beckett program in terms of institutional level of care, as well as the estate recovery that I think most of us are remembering quite well. In addition, our pharmaceutical costs were reduced when the Medicare Part D rolled out, and individuals who were duly eligible for Medicaid and Medicare could actually receive their pharmacy benefit primarily through the Medicare program Part D. In 2007, our focus was on the ASO companies that helped us in the age-bound disabled population to address nursing home level of care determination, clinical reviews, and were of assistance to us in evaluating fraud and abuse. The culmination of all of these efforts and initiatives, was it something I said? Okay. Was the reduction in the Medicaid expenditures. We started with a historical very high rate of annual growth in Medicaid expenditures of a high of 17%, double digit, beginning in fiscal year 2002, a reduction to as low as 0.6% in fiscal year 2007. We're now at a more respectable level of about 4.5%, which is easily comparable with commercial plans. Okay, the next section is the actual presentation to you regarding the governor's recommendations to address state revenue shortfall for fiscal year 2009 amended. We'll start with the administration budget for the department. You will note that the governor's recommendation is to reduce the Department of Community Health's administration budget by $14 million or by 13%. This includes in the first category personnel services, which includes the reduction of salary and benefit dollars from the program, as well as the cut of 7 positions and continuation of a hiring freeze. In addition, regular operating expenses were also reduced. This is enterprise-wide with respect to the GATE 2010 telecom initiative. Travel freeze still remains in effect, and then support costs have also been reduced across the board for the department. Our largest area of contribution in terms of the cut comes in contractual services. General contract funds were cut $10 million. The health information exchange grants were cut $500,000. So the total reduction is $14 million for administration in the Department of Community Health for 2009 amended. To give you an idea of what the impact of the administrative cuts will be on contracts, we have some of the key ones listed for you. In the first bucket are contract costs that were reduced. The first was the MMIS, or the fiscal agent. We typically held on to some reserves to try to fund change orders in the event that there were changes made to the programs in Medicaid and Peach Care. Those funds have been depleted. Given the decline in enrollment in Medicare and the slow uptake of the enrollment in Medicaid buy-in programs, we adjusted the contracts for those programs to reflect a lower enrollment, and we were able to achieve a savings there. Second was a lower contract cost due to better negotiations during the procurement process. The EQRO, or External Quality Review of Managed Care, is something that we are required to purchase through contract by the federal government to assess the quality of care being delivered through the managed care companies. That contract cost was significantly lower than we had projected initially. We also had a lower cost in our successful procurement for a pharmacy benefit manager. The next item or next category are contract costs were avoided. These are contracts that were either delayed in their startup including one in the age-blind disabled population, but also some contracts that we simply have decided not to do, not that the work wasn't valuable, but if we had to prioritize, we decided to not do those works. And that included having an accountant come in and help us with our reconciliation of some of the federal funds, as well as purchasing some of the additional software that we thought would be essential in helping us do a better job in our fraud and investigative capacity. We also eliminated, once again, the Health Information Exchange pilot program. Grant funding for those programs is gone. In the Department of Community Health, Healthcare Access and Improvement, we had a little bit of personnel dollars in this as well that were reduced, as well as an additional one position cut. Regular operating expenses for this particular division was also reduced given the GATE 2010 Telecom Initiative. The biggest line item in terms of reduction for healthcare access and improvement was a decrease in contracts and grants amounting to $16 million. The $16 million reduction in grants and contracts includes the contracts and grants listed above. These were grants that were approved in last session to fund healthcare initiatives across the state. They include the Firefighters Burn Foundation, the Rural Health Primary Care Support Grants, the Georgia Association of Primary Healthcare Community Center Grants, including the Behavioral Health Expansions, the Safety Net Grants, the Healthcare Marketing Authority, and the Wellness Pilot that was anticipated. In addition, the Governor's Regional Rural Health Initiative has been discontinued, returning about $10 million in tobacco funds. So together, the admin budget and healthcare access budget for the department together would have been $132.5 million. The governor's recommended change is a reduction of $30 million for a total reduction of about 23.2% for these budget categories. Next, I'm going to talk about the reductions for the Medicaid and Peach Care for Kids benefits budget. This is a separate budget category, and you may recall that the instructions were to reduce the state funds for the Medicaid and Peach Care benefits by approximately 5%, or $113 million. The governor's recommended budget is based on projections given to him in November of 2008. At that time, the unemployment was thought to be maxing out at 7.6% by the third quarter of 2009. So based on those data, on that assumption, Medicaid enrollment was anticipated to increase by 10.8%, Peach Care increased by 5.8%, and then on the flip side, in terms of the expenditures, we anticipated then having a medical inflation percent of 4% for 2009, which impacts the amount of expenditures in the per member per month growth. For Governor Perdue's amended FY09 changes, he recommends the following in an attempt to achieve the 5% reduction in state funds for Medicaid and Peach Care benefits. Number one, and if you can read this, you can actually see the line items and the numbers that correspond with the tracking document that you have. Number one was the deferral of all the provider rate increases that were approved in fiscal year 2009. So this includes for physician services, for health check, for mammography, global maternity, ambulance, home health care providers, personal support for the waiver program. All of that was included, and all of that was recommended for deferral until fiscal year 2010 funds, pending fund availability. The second one was a deferral of the nursing home fair rental value increase and rate increase, that 1% quality assessment fee increase that was supposed to occur. The third was a delay in the use of the 75 ICWP waiver slots so that they would not begin for use until January 1 of this year, as opposed to beginning in July when we anticipated them beginning. The fourth is the return of savings that we have reassessed given the success of the cost containment efforts in the previous year. And then the next is a decision made to use additional prior year reserves to assist in funding the 09 budget. New cost containment initiatives also included in the governor's recommendations are the use of the Paris Initiative, which essentially allows the state of Georgia to participate along with 45 other states in sharing of data for public assistance eligibility, as well as sharing of information with the federal government so that we would have access to information regarding individuals who receive federal benefits, as well as know whether or not individuals are also eligible for Veterans Administration health care benefits. The next is a effort in conjunction with DFAC's offices to help remove on a more expedited basis those individuals who are ex parte Medicaid members, meaning that they are currently enrolled in the Medicaid program, but something has changed in their eligibility, which makes them ineligible. They have to actually be removed from the program in order to stop receiving services. And at the same time, it's important for us to be able to do this as expeditiously as possible, since our managed care contracts are per capita, so we don't need any additional numbers listed if they don't need to be served. The next is the additional use of provider linkage software, which is a case tracking system that will allow us to track investigations for overuse, abuse, and fraud in the Medicaid and Peach Care programs. It also would allow us to track relationships and trends in different providers across different sectors of the healthcare community. This is a summary sheet that outlines pretty much what I've just listed out for you, but puts dollar signs next to them, so that the provider rate increase delay would allow a $59 million state fund reduction. The additional savings by continuing with the cost-containing initiatives from 08 into 09 would be an additional $54 million in savings. The use of prior year reserves would account for another $14 million being added into the amended 09 budget. And then in addition, there were some changes that had to be made to the CMO existing fee and nursing home existing fee. And then the next, which is the next biggest category, was the supplanting of state funds with tobacco funds for an amount of $59.7 million. All of these changes added together reveal a net reduction in funds for the Medicaid and Peach Care program of $136.7 million, or 5.9% reduction. This next diagram is a graph that basically illustrates the changes in the major funding sources. The light blue represents the changes in the in the state funds itself, going from $2 billion to $1.8 billion in the amended recommendations. The dark blue representing the change in tobacco funds, going from $50 million in the original 09 to the recommended now of $110 million. And the greens, both light and dark, actually represent the current fees that we currently have in place with the CMO and nursing home, which almost net each other out. The CMO is a slight decrease and the nursing home is a slight increase. What I have just showed you is the recommendations for the 09 amended, given the November 2008 projections that were available to the governor. What I'd now like to do is give you additional information regarding updates given the newest projections released in January 2009. So I'm going to give you the updates in terms of what the unemployment is supposed to be, the unemployment is projected to change to, as well as changes in Medicaid and Peach Care enrollment and the medical inflation rate. This first chart is actually showing the change in the unemployment projections, comparing October 2008 projection to January 09. The red is the actual unemployment rate going in through July of 2008. Green triangles represent the unemployment projections based on October 2008 data. And the blue above it represents the revised projections for unemployment based on January 09 data, with the assumption being that unemployment would max out at 9% in the fourth quarter of 09. What's going to be striking is looking at the shape of this graph for unemployment and then comparing it to the next, which is quite remarkably similar and illustrates the changes in the projections for the low-income Medicaid population, so predominantly children, but also includes pregnant women as well. It mirrors unemployment graph tremendously. I cannot overstate that. The dark blue bars represent the actual enrollment. The white is what was projected to occur as of October 08 data, and then the blue dots represent some revision with a slightly higher projected increase in the Medicaid enrollment. So as the unemployment increases, the number of families with decreased incomes occurs, as well as the number of uninsured who then seek us out, particularly to get their children enrolled. I did not make a slide for the Medicaid age blind and disabled because pretty much it is flat growth. We are not anticipating any significant increase in that enrollment, irrespective of the unemployment rate. The next is the revised projections for the Peach Care for Kids program. And I know I've discussed this with some of you before, but Peach Care for Kids enrollment is currently still declining, although the rate of decline is not as significant as it was several months ago. We do anticipate, however, that it will begin to increase upward based on the January 09 data. Medical inflation has changed again on reevaluation for the projections, and it has changed in our mind for the better. The original medical inflation for 09 was thought to be 4%. It has been decreased down by our national source to 3.3%, which should result in lower expenditures for us per member per month. So with the revised data, once again, the Medicaid enrollment growth is thought to now be increasing at a rate of 12.6%, Peach Care at 4.1%, and medical inflation of 3.3% for the remainder of fiscal year 2009, based on January 2009 data. The next slide is a summary of the changes between the two, the original governor's recommendation, as well as the January updated projections. So what is the bottom line? The bottom line is that the increase in enrollment based on the new projections is pretty much offset by the reduction in PM cost because of the lowered medical inflation rate. However, we do need to note that we will be just making it through the last week of June with the current recommendation on the table. Should the enrollment increase higher than what we have projected, we will not have sufficient funds to actually make it through the end of the fiscal year ending June 2009. The next part of the update for you is the state health benefit plan itself. The state health benefit plan has done well in fiscal year 2008 and is anticipated to do well in 2009. Employer contributions to the total revenue are $2.1 billion. Member premiums, $624,000. All total together with other revenue, $2.7 billion. Total expenses for the state health benefit plan in fiscal year 2008 was $2.5 billion, leaving that surplus that I mentioned earlier of $225 million, which went to the fund balance. The governor's recommended budget for fiscal year 2009 amended addresses the use of the fund balance. As we just said, for June of at the end of June 30th, 2008, the fund balance was estimated to be $472.9 million. That includes that $225 million that I just spoke to you about. By updating our projections, we now note that by June 30th of 2009, the fund balance for the state health benefit plan will be $672 million. The governor's recommended budget change for fiscal year 2009 includes taking $535 million of the $672 million and allowing it to be depleted in the manner of decreasing the employer contributions so that we would spend that money down. The reduction in employer contributions for the state agencies would be from 22% to 1.9%, for the local boards of education from 18 to 8.5%, with a 50% reduction in the Department of Education's contributions for school employees. In doing so, that would leave the state health benefit plan fund balance residual of about $136.9 million in reserve. This is separate and apart from IBNR reserves that already exist. The next slide is an illustration of the SHBP fund balance to illustrate again that by the end of fiscal year 2008, the fund balance had $472 million in it. And then the change that was anticipated by actually changing the employer contribution and reducing the fund balance by $535 million, leaving the $136. Summary of the overall department budget. For the Medicaid program, the governor's recommendations result in a change or a reduction of 5.6% in state funds for the Medicaid benefit budget itself. For the Peach Care budget specifically, this represents a 22.4% reduction in state funds. For the administration budget for the department, this represents a 13% reduction, and for the healthcare access grants and contracts, it represents a 64% reduction. Overall, state funds for the department would reduce by $164 million for 6.5% decline. That concludes my presentation of the department's budgets for Medicaid, Peach Care, State Health Benefit Plan, Admin, and Healthcare Access. I'm happy to take your questions.
Thank you. Any questions? Okay. Okay. Representative Gardner.
Thank you very much, Mr. Chairwoman. First question has to do about the decline in Medicaid and Peach Care, the eligibility. I yesterday asked the DHR commissioner about coordination of getting eligible for Medicaid and getting eligible for Peach Care, and how to make it easier for consumers to go through that process.
Did she talk to you about the joint effort we have with Joe Doyle?
Not very much, but tell me a little bit about it.
There's actually a consultant, and I can't remember, is it Georgia Tech? One of the universities is working with Joe Doyle, the governor's customer service champion, to actually figure out a way to do the faster, friendlier, quicker service.
So one-stop shopping for...
Yeah, to pull it all together so that that there's a coordination so that individuals, when they're moving from Medicaid to Peach Care or Peach Care to Medicaid, that they actually have a much smoother transition. So they're
or they
trying
just go in and they don't know where they fit?
Yeah.
That'll work?
The same thing.
Okay.
The same thing. And what I'd like to do is be able to give you a status update of what they've been able to achieve in terms of reducing the timelines, reducing the number of handoffs, reducing the number of times that people are transferred from 85 different people when they try to get one question answered. I can present that to the committee for your review as well.
Go to DFAC's office and their worker is furloughed? Or?
Right, because it's DFAC's, it's RSM workers, it's also the Peach Care eligibility workers, and all of them have to be coordinated in their efforts to get this done.
And do you think there are fewer in those programs? I mean, you had raised the eligibility guidelines just a little bit, and I mean, did you find that people were not eligible, or what were the facts around your...
We're talking about the verification?
More stringent verification.
Right.
Yeah.
For Peach Care, we found that when we did the citizenship, I think there were only about 6 real individual people who were turned down because they were not able to demonstrate that they were citizens. The biggest impact was actually on income verification. That we found that individuals who were not able to or did not complete the income verification or didn't qualify. Incomes were above.
Do you mean they made too much money? Or
made too much money.
Or they couldn't demonstrate their income?
Or they realized that we were going to check and find out that they made too much money.
Were there people that didn't have the ability to demonstrate their income because they didn't have...
I don't know that they actually couldn't demonstrate it. I think some of them actually... It's going to be hard for me to tell you off the cuff, okay? But I think we gave them a variety of different ways to be able to prove it. Plus we have our own data systems and data banks that we can actually access, the Department of Labor, things along that lines that we're able to access. And we are actually working with the Department of Revenue now on trying to figure out how we can actually access information about annual adjusted income that individuals have.
Okay. Thank you. I have a couple more questions if nobody else.
I think Representative Hewley has some questions.
Thank you. Madam Commissioner, Would you talk a little bit more under your new initiatives? You talk about using the provider linkage software to identify fraud. What are you finding, or what do you anticipate that you're going to find with that?
I'm anticipating that if once we get, this is case tracking software, I'm anticipating that what we should have is one streamlined system so that when the complaint, concern, audit finding comes up, that from the minute the case is open, all the way through to when it is referred to the Medicaid fraud unit or to local law enforcement or to the federal law enforcement, we actually have one streamlined system. No paper, nothing gets lost. There are deliverable dates that have to be met. There are reports that have to be done on a regular basis through the system, so there's less of a chance of things being left on a desk, of things being lost and not followed up on. Because part of the whole thing about if you go in and you identify abuse or overuse or fraud, but you don't actually work the case all the way through to actually try to achieve recovery, we're not achieving anything. The other part is actually to make sure that we identify trends going across the board, and the case tracking information will allow us to do that across providers.
Okay, I'm sorry. Thank you. I have a question. I know you talked about the impact of disease management for ABDs. How much savings did you see from using the disease management?
We are doing the second year of analysis now. The first year analysis revealed over $39 million in reductions for the end of fiscal year 2007.
Thank you. Representative Gardner?
Thank you. Would you look with me for a minute on page 8 at the trends over the years? I noticed in 2004 there was a significant reduction in the expenditures.
Yes. The 0.6%? Is that what you're looking at?
Yep.
Mm-hmm. When everything kind of hit at the same time.
In
all of the efforts.
2005, it looked like it continued down.
Yes.
The implementation of the CMOs occurred at the end of 2006, is that correct?
Yes. And that's also about the same time that the disease managements were wrapping up too. So I think it's a combination.
Okay. And then, the CMOs it appeared that they achieved some significant, or maybe not so, some savings. But the following year, then they went back up again to where they were before you implemented the CMO program. So
You're talking about the 4.5%?
Correct.
But in between that time frame is when we took out the 65,000 duplicate IDs as well. So there may be some artificial lowering of it. Remember, we found the 65,000 duplicates, and we went back and recovered the capitated payments that we had made to vendors, including the CMOs, Maximus, et cetera, et cetera. So I think that's not just that the CMOs and disease management made it go down to 0.6. I think it's because the actual enrollment and the costs that were associated with having duplicates in the system was reduced.
And then, but the next year, then it went back up.
Went back up to what is probably a more realistic number for us. There's going to be some growth in expenditures and healthcare costs, just by virtue of medical inflation itself.
But is the increase in cost, is the increased medical inflation helped by the CMOs or not? I guess is really my question.
What do you mean?
Well, it seemed to me that if I look at 2004, I see efficiencies in your system that allowed us to reduce the expenditures. I mean, things that you were already doing. And I'm, again, looking for the value added by the CMOs to see whether it was a one-year aberration or whether the cost of the CMOs was going to continue to increase. Or
each year they contribute, but they're not the sole source of savings. The CMOs are managing the low-income Medicaid and the Peach Care kids. So if they achieve 11 million in 08, 18 million in 07, that's part of the savings. The biggest savings is coming from the age-blind and disabled population with the use of disease management, source, et cetera. There's a host of things. That's where the biggest costs are, and that's where the biggest thrust is in trying to control some of those costs.
Thank you.
Have any other questions? No? Oh, go ahead. Representative Gardner? You're allowed.
I have heard from some of the retirees that the concern about the retirees' cost of their insurance being going up too much. Can you tell me something about what's happening? Do you manage the retirees' health benefits?
Yes. Are you speaking about the change for the Medicare B?
I think it's all entwined in the requirement to be in Medicare, but their premium costs have increased significantly, whereas the current employees, the premium costs are not.
No, it's the same rate.
I'll forward their question to you so
Okay.
that we can figure out what's really going on.
Okay.
Thank you.
Yes, I have another question. I know you discussed state health benefit employer contributions and the reduction. And have you included the furloughs into your projection?
No, we did not have furloughs because we actually have been able to achieve the administrative cuts. I'm sorry?
In a,
Yes.
okay.
Yes.
Okay.
That and the hiring freeze is the whole 9 yards, yes.
Okay, great. Thank you. Any other questions from any members? Yeah, that would be great. Thank you.
Could you speak a little bit about the reorganization and how the public health part of how that's going to work out from your perspective and how that's going to be coordinated with what you do?
Okay. I think that today, it's supposed to be happening today, I think the HHS reorg legislation is supposed to be released today. And in that legislation is the creation of a new Department of Health. And in that new Department of Health are all of the program and division areas that are currently in the Department of Community Health, as well as the newly transitioned Public Health Division from DHR. And to answer the earlier questions about the attached agencies that were here, they're still attached. Okay? We didn't lose them. They're still attached. Public health we see as both a resource on what I'm going to call front end and on back end care in terms of addressing healthcare strategy, population, demographics that we need to address with the state as a whole. Georgia should no longer be the 41 or 40th state in terms of United Healthcare ranking of states in terms of achieving healthcare improvement. So they're going to be able to provide that information to us. On the back end also, they're going to be able to hopefully be interested in providing some clinical care in the county health departments themselves. So we're seeing what we believe is going to have to be a major transformation in how we do business because we're bringing in individuals who will have expertise on the front end, healthcare assessment, epidemiology, strategy, and then also on what I'm calling the back end, the actual delivery of healthcare services overall.
After we get into a brighter economic outlook, do you think we will actually be providing more service through our public health departments because over the last few years their funding has really gone down, but the people did not go away that needed those services? Do you anticipate, I know where we are now, but do you anticipate under better economic times we'll be able to readjust how we have actually looked at the value?
Representative, I certainly hope so. I do know the value of having a fully funded, well-equipped, and resource-equipped county health department in the community. That is invaluable.
Thank you. All right, my stalling is over.
Representative Gardner.
I've been following the stimulus package to a certain extent and have noticed the possibility of changes in the FMAP. I'm looking at page 2 where you say the current FMAP is 64%. What are you expecting, and can you give us a clue about how that will help us?
Yeah, while Carrie is pulling up the slide so that I don't crash the laptop again, I can kind of review with you what we've already have been able to obtain in terms of information. For the House stimulus proposal, They're proposing a 4.9 percentage point increase, which would mean 64 plus 4.9, so 68.9% federal match for Medicaid only. This is not for SCHIP. This is for Medicaid only. That increase or enhanced match would be in effect from October of 2008 to December of 2010. We anticipate that at a minimum then the state of Georgia would receive for the fiscal year 09 $514 million, for fiscal year 2010 $775 million, and for fiscal year 2011 $404 million, for a total of $1.6 billion in additional funds under the House proposal. On the Senate side, the Senate proposal, the recommendation so far is for a 5.6% point increase. So again, 64 plus 5.6, 69.6%. And again, for the impact for Georgia for 09, $464 million additional, 2010, $721 million, and for 2011, $376 million, for a total of $1.5 billion additional. What I did not address was what in the middle there, where it talks about the high unemployment rate add-on for those states that have high unemployment. We're anticipating at the rate we're going that we'll qualify for something in that mix. There's a sliding scale for additional match if a state is experiencing rapidly increasing unemployment, and we'll have to get you more details about how that would be applied. And in addition, aside from this, remember there's also the component about COBRA assistance, and then another proposal on the House side about a temporary 100% federal funds for the unemployed.
Up to?
I don't remember there actually being an income level limit on it. Was it 200? Okay.
Do you have any idea of the impact of that?
No, I don't, not yet.
Is that something you'll be able to administer
With your help, yes.
And were they providing some help for the administration or new enrollees?
To answer your question, yes, they will pay 100% of that plus an admin fee. That's in the House proposal. As you know, it's in the Senate, and they'll do their version, and then there'll be a conference committee, and we don't know for sure what it looks like, but right now it looks good. Commissioner, I don't see any more questions.
Thank you.
Thank you. We stand adjourned.